Hi everyone, welcome to OneMedicine. This is Dr. Srihari Kulkarni, and in this video we'll be looking at rapid revision of hematology lectures. So as this video is a rapid revision, we won't be getting into in-depth explanation of each of these topics. So we'll be skimming through most of them, also covering the important points and explaining wherever it is necessary. Most of the topics are taken from Harrison's Principles of Internal Medicine, but some topics are beyond Harrison, so notes of whichever is there is made, and wherever it is required it is explained at relevant sites. So let's start with the first topic, that is examination of bone marrow and blood smears. In blood smears, first topic is RBC morphology. So RBC is also called as erythrocytes. The normal size of RBC is 7.5 micrometer, which is also approximately equal to the size of a small lymphocyte or the nucleus of a large lymphocyte. Another important cell type in RBC lineage is reticulocyte, which is a precursor of RBC, and it exhibits polychromasia. So what is polychromasia? On Wright's staining, the RBCs have grayish blue with admixed pink staining. And as there are multiple colors that are seen, that is grayish blue as well as pink color, it is called as polychromasia. Now let's look at the variations in the RBCs. There is first one which is called anisocytosis. What is anisocytosis? It is the variation in RBC size. So variation in RBC size is called anisocytosis. Another important word is poikilocytosis, which is variation in shape. Variation in shape. An easy way to remember is poikilo P and shape P. Let's look at anisocytosis. In anisocytosis, we have size variation. So there are large cells or macrocytes. There are small cells or microcytes. Large cell in a peripheral smear usually indicates a delay in erythroid synthesis. So some of the examples include B12 deficiency, folate deficiency, and there are certain drugs which cause macrocytic picture. Small cells indicate defect in hemoglobin synthesis, and some of the examples of this include iron deficiency, abnormal hemoglobin genes. Let's move on to the next topic, which is red cell distribution width, or commonly known as RDW. This is the variation in RBC size. The numbers, the normal range usually is from 11 to 14, and this indicates the variability in the RBC size. So if we take an example in a normocytic picture, of a normal individual, all the red cells are almost equal in size. So here the RDW will lie within 11 to 14. 11 to 14. This is a clearly understood concept. In case of a B12 deficiency smear, we'll be looking at macrocytes, which are huge cells, and then there are some normocytes as well, that is the normal cells. So as we can see, there is a huge variation in the size. There will be an increase in RDW. Now let's look at another example of pure microcytes. So in the entire smear, we are seeing only very small or tiny RBCs. Here, even though there is a variation from the or deviation from the normal size, the RDW is going to remain within the normal range itself. This is because the variability is less. So there is no variability, and because of which the RW will remain within the same range. The second concept, that is poikilocytosis, which means the variability in shape. As I mentioned, P for poikilocytosis, P for shape. So there are different examples in this, and we look at each of them. First is acanthosis. Acanthosis, which is also called as spur cells. Spur cells, these are irregularly spiculated RBCs seen in A beta lipoproteinemia, severe liver disease, and also sometimes in anorexia nervosa. Second type is echinocytes. These are also called as Burr cells. Acanthocytes were spur cells and echinocytes are Burr cells. So what are Burr cells? These are regularly shaped RBCs, but they have uniform distribution of spicules. Spicules are just spines. So there will be spines spread all across the RBCs, whereas in acanthocytes, they are not so uniform. So one will be here, one will be here, something like this. So this is what we will see in acanthocytes, and this is what we will see in echinocytes. Echinocytes are classically seen in patients with volume loss and in patients with uremia. Third example of poikilocytosis is elliptocytes. These are elliptical cells as mentioned in the name. They are seen in hereditary elliptocytosis. Fourth is schistocytes. So these are broken cells or schistocytes or broken RBCs. They are also called fragmented RBCs. They can also be of variable sizes. So the fragments can be of variable sizes, and this indicates angiopathic hemolytic anemia. Angiopathic hemolytic anemia, or also called as intravascular hemolysis, both macroangiopathic and microangiopathic hemolytic anemias. Next type is sickle cells. Sickle cells. These are sickle shaped as mentioned in the name, or also elongated crescentric RBCs, and they are seen in sickle cell anemia. Sickle cell anemia. The next type is spirocytes. Spirocytes are small hyperchromic, which means all the hemoglobin is concentrated in one place, which is why the patient's RBC indices of mean corpuscular hemoglobin concentration will be elevated in these patients, and lack central pallor. These are seen in patients with hereditary spirocytosis or in patients with extravascular hemolysis, as seen in autoimmune hemolytic anemia patients, G6PD deficiency. Another type of poikilocytosis is target cells. They have a central and outer rim staining with an intervening pallor. So these cells look like this. So there is a central staining, there is an outer rim of staining. So as there is no central pallor, this will look like these target shaped cells. They are seen in a lot of diseases including liver disease, thalassemia, hemoglobin C, sickle cell, and so many other conditions. An eighth subtype is teardrop cell. They are in the shape of a teardrop, and they are also called as dacrocytes. One easy way to remember is wherever we see dacrocytes are the conditions where RBCs have to literally squeeze out of bone marrow. So that is why they have these dacrocytic shape or teardrop shape. And the examples for this include myelofibrosis, bone marrow infiltrative disorders, and certain carcinomas. Now, what is rouleaux formation? Rouleaux formation. So, rouleaux formation is alignment of RBCs in stacks. They can be a sort of artifact when they are present in thick part of the peripheral smear, and they are also seen in paraproteinemias such as multiple myeloma or macroglobulinemia. Now let's look at RBC inclusions. So these are structures seen within the RBCs on a microscope in a peripheral smear. Howell Jolly bodies. These are usually 1 micrometer in diameter and have basophilic cytoplasmic inclusion. So what is basophilic? It means bluish color. Eosinophilic is reddish colored. So wherever we hear the word eosinophilic, then it means that it is a reddish colored inclusion, and wherever we see basophilic, it means a bluish colored inclusion. So these Hubble-Jolly bodies are usually single, and sometimes maybe two of them can be seen within an RBC itself. These Hubble-Jolly bodies indicate a residual nuclear fragment and are seen in asplenic patients, that is, patients without spleen. The second type is basophilic stippling. So basophilic stippling is basically multiple, as against the Hubble-Jolly bodies where there is only one. These are multiple punctate basophilic cytoplasmic inclusions. They are usually composed of precipitated mitochondria and ribosomes. These are classically seen in lead poisoning. They can also be seen in thalassemias and myelofibrosis. Another type of inclusion is Pappenheimer inclusion or iron inclusion. As the name mentions, these are iron-containing granules and are basically seen in ribosomes and mitochondria. The only difference between this and basophilic stippling is that these also stain with iron staining, and one of the most important iron staining is Prussian blue staining. So basophilic stippling also has a very similar pattern with multiple stipplings of bluish color, but they do not stain with Prussian blue. So Prussian blue staining is not there in basophilic stippling. Heinz bodies. These are precipitated hemoglobin seen only with supravital stains such as crystal violet. They are seen usually in patients with G6PD deficiency after an oxidative stress such as an infection or an injury. So this leads to precipitation of hemoglobin, which are seen as Heinz bodies. Another place where Heinz bodies are seen is unstable hemoglobin variants. Other possible inclusions within the RBCs include parasites. Some of the examples are malaria and babesiosis or babesia. Now let's move to WBC morphology and nuclear contour abnormalities. The first one amongst these is toxic granulations. So the toxic granulations are dark cytoplasmic granulations seen in bacterial infections. The second type is Dole bodies. These are classically seen in Chediak-Higashi syndrome, but they can also be seen in bacterial infections. These are described as 1 to 2 micrometer blue cytoplasmic inclusions. Third type is rods. So these are eosinophilic or red colored on staining in peripheral smear, rod-like cytoplasmic inclusions seen in some subtypes of acute myeloid leukemia, hyper segmented neutrophils. In a peripheral smear, the neutrophil looks somewhat like this. They will have these segments within the nuclei. So this is one segment, this is the second segment, and this is the third segment. In a normal smear, we see 2 to 4 segments within the nucleus of neutrophils. But if a patient is having more than 5% of the cells of the neutrophils with more than or equal to 5 segments, or even one cell with 7 segments, then we can call it hypersegmentation. And this condition is usually seen in patients with B12 deficiency or in patients with drugs affecting the cell maturation. Next, we will jump to platelet abnormalities. The first one is platelet clumping. This is a commonly encountered issue within the laboratories, and this is a in vitro occurrence where the platelets clump together and are counted as a single platelet. So around 4 to 5 or even 10 platelets can be counted as a single platelet. This leads to pseudo thrombocytopenia. These are usually seen in blood samples where EDTA is used as the anticoagulant. So to prevent this, a citrate tube or a citrate anticoagulant is preferred. Second is giant platelets. A normal platelet size is around 5 to 6 micrometer. So whenever there is a more than 6 micrometer platelet, that is known as a giant platelet. And this indicates that there is an increased production of immature platelets or young platelets. This can also cause an apparent thrombocytopenia, as these giant platelets are not counted by cell analyzers. Next, we look at bone marrow. In bone marrow sampling, we have two important types, that is aspiration and biopsy. As a simple rule, aspiration assesses morphology of the cells, whereas biopsy assesses the architecture of bone marrow. Whenever a biopsy and aspiration are being obtained together, biopsy should be taken first and then aspiration should be done. And if it is reversed, and that is if the aspiration is taken first and then followed by biopsy, this can lead to something called as a bleeding artifact and wrong reporting of biopsy. Now let's look at the indications of bone marrow aspiration and biopsy. So these are usually performed in hypoproliferative anemias or unexplained anemias, leukopenias, thrombocytopenias. In a case of suspected hematological malignancies such as acute and chronic leukemias, myelomas, in evaluation of iron stores, in evaluation of certain cases of fevers of unknown origin, and also lipid storage disorders. Let's briefly touch upon the interpretation. First heading is cellularity, which is the percentage of space occupied by hematopoietic cells. So the space that is not hematopoietic tissue is usually occupied by fat. The cellularity decreases with age, with an initial of 50%, gradually reducing to 25 to 30% as the person ages. Next we have erythroid granulocytic or erythroid myeloid ratio. This is usually 1:2. Next we have erythroid granulocytic ratio or erythroid myeloid ratio. The numbers are usually 1:2 and they are reduced in certain conditions and they are increased in certain conditions. So let's look at the conditions where erythroid myeloid ratio or erythroid granulocytic ratio are reduced, and these include chronic and acute infections, leukemoid reactions, leukemias, myelodysplastic syndrome, and pure red cell aplasia. Conditions where erythroid granulocytic ratios are increased include agranulocytosis, anemias with hyperplasias. So these include megaloblastic, iron deficiency anemia, thalassemia, hemorrhage, hemolysis, sideroblastic anemias, and erythrocytosis. So as a generalization, all the conditions that reduce the RBC production or increase the myeloid lineage will cause a reduced erythroid myeloid ratio, and all the conditions that cause an increase in the RBC production and reduction in the myeloid lineage will cause a increased erythroid myeloid ratio. Let's look at red blood cell disorders. In this part, we'll try to get an overview of all the red blood cell disorders, and we'll delve into each of these topics in further parts of the video. So first is anemia. This is reduction in hemoglobin for that age and gender. So there are various reasons why anemias can happen, but these are broadly classified into three categories. Anemia due to reduced production, and anemia due to increased destruction. Third is anemia due to blood loss. This is further subdivided into acute blood loss and chronic blood loss. So the first type of these is hypoproliferative anemia, where there is reduced production of red blood corpuscles. These may happen in early iron deficiency, reduced erythropoietin levels, or marrow damage. Usually the RBC morphology is unchanged, but the reticulocyte index will be decreased. Now some of the causes for marrow damage includes marrow infiltration with a tumor or fibrosis, or absence of RBC precursors. This happens in aplastic anemia. This can happen secondary to drugs or radiation or viruses, including hepatitis or parvovirus B19. Marrow destruction can also happen because of autoimmune mechanisms or genetic variations, including Fanconi's anemia, or it can happen because of an acquired cause, such as in paroxysmal nocturnal hemoglobinuria. The tumors or fibrosis that infiltrates the marrow can originate within the marrow or outside of marrow. Within the marrows, the examples would include leukemia or myelofibrosis, whereas outside of marrow can be seen in metastatic tumors or myelophthisis. The early iron deficiency anemia is usually associated with a reduced serum ferritin level, elevated total iron binding capacity level to usually more than 350 to 380 microgram per deciliter, a serum iron level of usually less than 50 microgram per deciliter, and iron saturation of less than 30% but more than 10%. RBC morphologies are usually normal until there is severe iron deficiency. Decreased stimulation of erythropoiesis, this can be due to reduced erythropoietin production, such as seen in renal disease, or hypometabolic states such as endocrine deficiencies or protein starvation. In both the cases, there is reduced erythropoietin production, which further reduces the RBC production. In general, in older people, erythropoietin levels usually increase to maintain the normal hemoglobin level. So if this increase is not happening properly, that can also lead to anemia. So around 11% of older adults more than 65 years of age, or up to 45% of nursing home residents usually have reduced erythropoietin level, and this can lead to anemia. Another common entity is anemia of chronic disease. Here, the pathogenesis of anemia is by reduced erythropoietin production, reduced erythropoietin reutilization, inhibition of erythroid colony, usually due to inflammatory mediators. An important concept here is hepcidin. This is a small iron binding molecule that is produced by liver, and it increases during acute inflammation. So it's a positive acute phase reactant. So this reduces the binding of iron and also reduces the reutilization of iron for hemoglobin synthesis. Next, there are maturation disorders. So these result either from defective hemoglobin synthesis, leading to defective cytoplasmic maturation, and small and empty red blood cells, or abnormally slow DNA replication, leading to nuclear maturation defects. Where there are large RBCs. The defective hemoglobin synthesis can happen because of two reasons: a defective heme and a defective globin. A defective heme will happen because of a severe iron deficiency anemia or severe iron deficiency, whereas a defective globin can happen because of hemoglobinopathies, including thalassemia. Whereas nuclear maturation defects can happen due to defects in the DNA synthesis that can be due to nutritional, including a vitamin B12 or folate deficiency, due to toxins or drugs. Examples include methotrexate and other chemotherapeutic agents, or intrinsic maturation defects, such as the one seen in refractory anemia or myelodysplasia. So there are various measurements within the RBC as well as erythropoietin levels which are used to diagnose various types of anemia. Let's look at each of these. Here we have the level of anemia, the mean corpuscular volume, morphology, serum iron, total iron binding capacity, saturation of iron in percentage, iron stores, and erythropoietin levels. In case of an iron deficiency anemia, the anemia can be mild to severe depending on the level of iron deficiency. Again, the mean corpuscular volume can be normal or it can be microcytic as well. Morphology is normo or microcytic depending on the level of iron deficiency. Serum iron is usually less than 30. Total iron binding capacity will be elevated to more than 350 to 360. Iron saturation will be in mild cases less than 30% but not less than 10%, and in severe cases it can be less than 10%. Iron stores are usually depleted, and in severe diseases it can be even zero. Erythropoietin is usually increased. This is a normal response to anemia. Next, we have inflammatory states, or these can also be called as chronic disease anemias. So here the anemia is usually mild and the MCV is usually normocytic or normal levels, and morphology is normocytic. Serum iron is within normal limits or slightly reduced, especially if it is chronic, owing to increased hepcidin and reduced iron absorption, whereas total iron binding capacity will be classically less than 300, and also serum ferritin will be increased. This is a very important marker. The iron saturation can range anywhere from 10 to 20%, again owing to hepcidin, increased hepcidin levels. Iron stores will be good, 2 to 4. Erythropoietin levels will either be normal or slightly elevated. Next is hypometabolic states. So these are usually seen in reduced protein intake and prolonged starvation, and as well as endocrine deficiencies. Here the anemia can be mild and mean corpuscular volume is usually elevated. It is above the normal levels, and morphology can be normocytic or macrocytic. And rest of the parameters are normal, that is serum iron is normal, total iron binding capacity is normal, saturation is normal, iron stores are normal. Erythropoietin level can be normal or it can be low also. In anemia secondary to aging, we can see a mild anemia, and the MCV will be somewhere in the range of 90 to 80 to 90 femtoliters. Morphology can be normocytic, and rest of the parameters are normal, that is serum iron being normal, total iron binding capacity is normal, iron saturation is normal, iron studies are normal, and even erythropoietin levels are normal. Here the main culprit is normal erythropoietin levels, because increased age requires increased erythropoietin, and because of a failure to increase in the erythropoietin levels, there is anemia seen in such patients. Now let's look at anemia secondary to blood loss and increased destruction. Blood loss. This can happen due to trauma, gastrointestinal bleed, which can be occult, but rarely it can also happen because of genitourinary sources, including menorrhagia, increased cyclical bleeding in females along with prolonged bleeding, and it can also happen because of gross hematuria. Although this is a very rare cause, there can be internal bleeding such as an intraperitoneal bleed as seen in spleen or liver or other organ rupture. There can be retroperitoneal bleed as can happen in iliopsoas hemorrhage, which is usually seen in hip fractures. Acute bleeding is usually associated with manifestations of hypovolemia, reticulocytosis, macrocytosis, whereas chronic bleeding is associated with iron deficiency, hypochromia, and microcytosis. Next we have hemolysis. Hemolysis is essentially destruction of RBCs. So the hemolytic anemias are classified as hereditary and acquired causes, and in each of these subheadings we have intracorpuscular defects and extracorpuscular defects. Examples of hereditary intracorpuscular defects include hemoglobinopathies, enzymopathies, membrane or cytoskeleton defects, Examples of extracorporeal hereditary causes include familial or atypical HUS or hemolytic uremic syndrome. Examples of acquired intracorpuscular defects include paroxysmal nocturnal hemoglobinuria, and examples of extracorpuscular acquired defects include mechanical destruction, which are usually seen in microangiopathic hemolytic anemias, or toxic agents, certain drugs, infections, and autoimmune causes. So let's look at some of these with a greater detail. So intracellular RBC abnormalities. So most of them are inherited enzyme defects. Here glucose 6-phosphate dehydrogenase is the most common, and then pyruvate kinase is another type of enzyme defect. Then there are hemoglobinopathies, sickle cell anemia, thalassemia, and there are unstable hemoglobin variants. G6PD deficiency, which is glucose 6-phosphate dehydrogenase deficiency. This can lead to episodes of hemolysis, usually secondary to oxidative stress on RBCs, and intake of certain drugs or medications can also lead to hemolysis in a patient with G6PD deficiency. Some of the examples of these include in antimalarials, primaquine, dapsone, or chlorproguanil, in sulfones or sulfonamides, sulfamethoxazole, or dapsone, antibiotics including clotrimazole, nalidixic acid, nitrofurantoin, niridazole. Others that are implicated in hemolysis in a patient with G6PD deficiency include naphthalene and methylene blue. Next condition is sickle cell anemia, which is characterized by a single amino acid change of beta globin chain. The change is in 6th residue, where valine is substituted for glutamic acid. This produces a hemoglobin molecule which has reduced solubility, especially in hypoxic states, and can also lead to sickling of RBCs. Sickling of RBCs. Although there is anemia and hemolysis in sickle cell patients, the most dreaded complication is vaso-occlusive crisis. Here there is vaso-occlusion because of misshaped RBCs. That is sickle-shaped RBC. This is how the sickle-shaped RBCs look on a peripheral smear slide. Let's look at the pathophysiology of sickle cell crisis. The hemoglobin of sickle cell disease is written as HbS. So in an arterial PO2, the oxyhemoglobin or oxy-HbS is soluble. But when it reaches the venous PO2 levels, which is the hypoxic state, then the deoxyhemoglobin or deoxy-HbS is polymerized. So this polymerization leads to membrane changes, that is sickling, at a microscopic level, but it also leads to increase in the calcium influx and potassium leakage. This has two effects. First one being capillary venule occlusion due to misshaped RBCs. This can cause microinfarctions. It can also cause ischemia. It can also cause organ malfunction, and rarely it can also cause autoinfarction of spleen. The other effect that membrane changes cause is anemia due to hemolysis, chronic hemolysis. Jaundice, again due to hemolysis. There can be gallstones. These are pigment gallstones. They can also cause leg ulcers. Next, we have membrane abnormalities. So these are quite rare. In that, spur cell anemia, usually seen in cirrhosis and anorexia nervosa. Paroxysmal nocturnal hemoglobinuria is another type of membrane abnormalities. Hereditary spherocytosis leads to increased RBC osmotic fragility and leads to hemolysis. Also, spherocytes can be seen in the peripheral smear. Hereditary elliptocytosis, which follows a similar mechanisms of hereditary spherocytosis, but only mild anemia is seen. Next subset of hemolytic anemias include immunohemolytic anemias. These are the anemias where Coombs test is positive. There are usually two types here: warm antibody, which is mediated by IgG for the most part, and cold antibody, which is mediated by IgM. Warm antibody hemolytic anemia. So warm antibody hemolytic anemia can be associated with lymphoma, chronic lymphocytic leukemia, systemic lupus erythematosus, and drugs including methyl dopa, penicillins, quinines, isoniazid, sulfonamides. Whereas cold antibody hemolytic anemia can be seen in mycoplasma infection. It can be seen in infectious mononucleosis. It can also be seen in lymphoma. It can sometimes be idiopathic, or it can be seen in paroxysmal cold hemoglobinuria, that is an IgG mediated disease. It can also be seen in infections such as syphilis and certain viral infections. Hemolytic anemia can also be caused by mechanical trauma. These can be both macro or microangiopathic. Peripheral smear classically shows cystocytes, that is broken RBCs. This can be seen in prosthetic heart valves, vasculitis, malignant hypertension, eclampsia, renal graft rejection, hemolytic uremic syndromes, disseminated intravascular coagulopathy, March hemoglobinuria. Other examples of hemolysis include infections such as malaria, where there is direct effect on rupture of RBCs, leading to hemolysis and hemolytic picture. There can be Clostridium perfringens, toxin-mediated hemolysis, toxoplasmosis, can also lead to hemolysis. Hypersplenism, where hemolysis is associated with pancytopenia. Laboratory evaluation of hemolytic anemia include that there will be an elevated reticulocyte index, there can be polychromasia or increased reticulocyte count, there can be nucleated RBCs seen within the peripheral smear, there can also be spherocytes or elliptocytes or cystocytes, there can be target cells or spur cells also within the peripheral smear. Increased levels of unconjugated bilirubin can be seen. Increased lactate dehydrogenase will be seen. Elevated plasma hemoglobin levels due to RBC rupture and leakage of hemoglobin into the plasma can be seen. Urine hemosiderin can be seen in intravascular hemolysis but not in extravascular hemolysis. Osmotic fragility test can be positive in hereditary spherocytosis. Hemoglobin electrophoresis can be used in diagnosis of sickle cell anemia or thalassemia. G6PD levels can be performed to look at deficiency, but these are usually performed after the episode of hemolysis has resolved to prevent false negative results. Treatment of anemia. General approaches. Acuteness and severity of anemia determine whether there is requirement of transfusion with packed red blood cells or PRBC. Rapid occurrence of severe anemia, such as seen in hemorrhages in the GI tract, that leads to a hematocrit of less than 25% or development of angina, is a indication of transfusion of RBCs. As a general rule, hematocrit should increase by 3 to 4% with each transfusion, or RBCs, that is hemoglobin, should increase by around 1 gram per deciliter for each transfusion. Chronic anemias may not usually require transfusion therapy, especially if it is compensated. In iron deficiency anemia, treat the cause of blood loss. Oral or parenteral iron can be used. In folate deficiency, commonly seen in malnourished alcoholics, folic acid can be given as 1 mg per day dosing and 5 mg per day for patients with malabsorption. Vitamin B12 deficiencies can be managed either with parenteral route, which is usually given as a dose of 100 microgram per day for 7 days, followed by 100 to 1000 microgram per month as IM dose, or with oral supplementation of 2000 microgram or 2 milligram of oral crystalline vitamin B12 per day. Anemia of chronic disease. Treat the underlying cause. In case of uremia, use recombinant erythropoietin in dosing of 50 to 150 international units per kg thrice a week. Whereas in other forms of chronic disease, erythropoietin is generally not preferred because the role is unclear. But if the erythropoietin levels are in general low in case of chronic disease, then erythropoietin administration can be used with a target hemoglobin of 9 to 11 gram per deciliter. In cases of anemia of chronic disease, iron supplementation or parenteral administration is not generally recommended. In sickle cell anemia, hydroxyurea given in the dosing range of 10 to 30 milligram per kg per day orally increases the level of fetal hemoglobin and prevents sickling. If there are any infections in a patient with sickle cell anemia, treat the infections early. Vitamin B12 and folic acid supplementation can be useful. In patients with vaso-occlusive crisis, they can be treated with oxygen inhalation, analgesics such as opioids to battle the pain, hydration, hypertransfusion. As a definitive treatment, allogenic bone marrow transplant can be taken in a patient with increased frequency of crisis. In cases of thalassemia, transfusion is done repeatedly. Transfusion of RBCs is done repeatedly to achieve a target hemoglobin of more than 9 gram percent or 9 gram per deciliter. Folic acid and deferrasirox, which is oral route of iron chelation therapy. Patients can also be taken up for splenectomy, and definitive management is allogenic bone marrow transplantation. Aplastic anemia. This can be treated by anti-thymocyte globulin and cyclosporin, which leads to reduction in aplastic crisis in around 70% of the patients. Bone marrow transplantation in young patients with a matched donor is definitive. Autoimmune hemolytic anemia can be treated with glucocorticoids and sometimes even immunosuppressive therapy can be used in case of failure to respond for glucocorticoids. Plasmapheresis, danazol, and even rituximab can be used. G6PD deficiency. Generally avoid conditions with oxidative stress and also avoid drugs that can induce G6PD deficiency.